At the outset, I would like to thank Myom for this opportunity, and Dr. Ramesh has covered it. And I don't know if there is any debate here. He has already said, consider the age, the eye, the most important. And I feel it should be the eye first and then the age, of course, because age comes second for me, because you have to analyze the eye whether it needs IOL, that particular eye, whether you can implant the IOL or not. Okay, let me start. To wait, there is no second thought for me. Definitely, I am not going to implant IOL in infants, and there is no doubt either. Let me look at the 10 things or the 10 commandments which is there in the Bible that I follow before implanting an IOL in any eye, any age. The first is the smaller cornea. Definitely, by age 1, the size is about 10 to 11.5 millimeter. And what is the size of our IOLs? Most of the IOLs is between 12.5 and 13. Can we really think that this IOL can be placed very well inside the bag? There is something that we should consider. We know that second factor is the corneal curvature. We know that there is drastic change in the first 2 years of life, and one diopter difference in the corneal curvature results in 1 diopter difference in the calculated IOL power, and eventually it is not the same that we are going to implant. We might be undercorrecting most of the time just to catch up with the growth of the eyeball. The third factor is the axial length. There is again a drastic change in the first 2 years of life. A 1 millimeter difference in axial length can change the IOL power by 2.5 diopter to 3. So the fourth factor, these two things determine the IOL power calculation, and hence what we are implanting is a big dilemma, because there is rapid increase in axial length and decrease in corneal curvature during the first 2 years of life, and this can lead to refractive surprises. Yet another factor is choosing the right IOL formula for these small eyes and getting the right IOL power. We need to undercorrect the IOL power, so this requires an examination under short GA. The fifth is the technical difficulties in these teeny mini eyes, whether it is really feasible to implant. Our aim should be to implant the IOL in the bag, and parameters like AC depth, pupillary dilatation, capsular bag volume to accommodate this big IOL is something that we need to consider. So is it justified? It is better that we don't implant at all if we are not aware what exactly we are looking at and what the brain doesn't know at all. I think better to defer it. Making primary IOL implantation under 1 year of it, definitely technically difficult. So these are the children who are wearing the FA glasses. Is there any child who is unhappy? No. No lens in sight, still vision is bright with spectacles and contact lenses. The seventh commandment would be, what about the outcomes after implanting an IOL? So we have, as Dr. Ramesh has described, there are higher rates of adverse events in the IOL group, and I'm not sure if there's any clear advantage of early IOL other than visual rehabilitation. Coming to refractive surprises, the eighth parameter or the eighth point to be considered is the post-operative refractive surprises, which could be a large myopic shift requiring IOL exchange. That means another surgery for the child. So when the eye is large and the child is grown tall, why not think of a secondary IOL? It can solve most of the problems. Coming to the ninth commandment, post-operative complications. It's really complicated. High risk of complications with various literature coming up as one important factor, that is visual axis opacification as major complication in the IOL group. So we need to take this child for another surgery. Of course, the other complications are glaucoma, uveitis and IOL decentration, which means there is a higher chance of resurgery. So this is a patient. On the left side, the picture is the same eye. It's a pseudophakic, developed glaucoma. This was, and the right eye, I left it aphakic. That eye never developed secondary glaucoma. So a lot of studies are mentioning that VAO was the most common post-operative complication. A large myopic shift was observed. This is by Dr. Ramesh himself. A lot of literature bringing about, of course, the glaucoma part is almost similar to the IOL group and aphakic group. But we can never say it depends on the eye and the kind of patients that we are seeing. These are many literatures coming showing that leaving children aphakic is better. The last parameter or the last commandment is the risky business. These children require multiple surgeries, and definitely it carries the surgical and anesthetic risk when there are reoperations. So there is a study, we have to weigh the balance between the benefit and the complications, and each child is different. We have to consider the age, of course, the eye, and the surgeon's experience. So let us not carry home the point that IOL can be implanted in these small eyes. Not only that, it affects the neurodevelopment of this child, that is multiple surgeries and anesthesia risk. Just one slide, last slide, please. So which is better? I leave it to you. On the weighing scale, you have one most important thing that we are all wanting is the early visual rehabilitation and a lower incidence of amblyopia by implanting an IOL in the young child, or on the other part, looking at the technical difficulties of implanting IOL, post-op surprises, larger myopic shift, higher chances of complications, higher resurgeries, and higher risk of anesthesia. I would wait and watch and then implant. Thank you.